Thank you very much. It's a pleasure to be here today, and especially to be on a panel with Julio. 14 years ago, Julio was my doctor, and I was looking at a pretty poor prognosis. We were working on salvage therapy. I was planning a once-in-a-lifetime trip to Australia. He sat down and told me I should go, but that the future might not be quite as bright when I got back. 14 years later, this is now my fourth trip to Australia, and I continue to, the last three times I've come to talk about HIV, human rights, and I'm here to stand up and to talk for the people who didn't make it, and for those who couldn't be here. Julio, you also taught me not only a lot about science and treatment, but how to challenge authority. We didn't always see eye to eye, but I think that's part of the process. So, I'm here to talk about the opportunities and challenges that treatment as prevention, both as a public health policy, but also on the individual level in terms of keeping people alive and also greatly reducing our infectiousness, and how that works within a human rights framework. So, the opportunities of a policy of treatment of prevention include creating very real incentives for policymakers, funders, and government to move towards universal access to treatment, which will benefit, of course, people's health, people living with HIV's health. This would help fulfill the right to life, liberty, and security, as well as the right to the highest attainable standard of physical and mental health. Of course, we're talking mostly about the global south, but it also can affect the global north too. For example, in England, where I'm from, the concept of treatment as prevention on an individual level was used to help argue for access to free HIV treatment for irregular migrants on the basis of benefiting public health. Another opportunity is the way the individual effect of treatment on infectiousness can reduce stigma via reducing the fear of contagion, that has seen a positive impact on the right to non-discrimination and equal protection before the law. For example, in overly broad HIV criminalization, I'll give you an example in a moment. The right to education, for example, allowing children with HIV to go to school. The right to found a family, for example, easier access to conception for serodiscordant couples using treatment, sometimes in combination with PrEP, rather than much more expensive assisted conception methods that are inaccessible to many couples. The right to work, for example, the improved occupational exposure policies that allow dentists and surgeons who are on treatment with a low or undetectable viral load to continue their profession. And the right to freedom of movement, for example, the easing of travel restrictions. However, treatment as prevention as a public health policy may also be a double-edged sword, and could also, theoretically at least, negatively impact the right to liberty and security, for example, if forced into treatment. Now, less theoretically, the right to non-discrimination can also be impacted. For example, the selective prescribing of antiretroviral therapy to certain groups based on their public health priority. For example, if a person living with HIV is part of a serodiscordant couple, or prosecutions for potential HIV exposure that now will only focus on people who are not on treatment or who have not, for many reasons, achieved a low or undetectable viral load. And until the results of the START study are in fact in, a policy of treating above 500 CD4s may potentially impact the right to the highest attainable standard of health if it's found that earlier treatment is some way potentially harmful to the individual despite the public health benefit. There are also issues around the right to privacy. For example, name-based reporting could also mean people who are formally lost to follow-up are tracked down and strongly encouraged to take treatment. And finally, there are some very real concerns about the right to receive information. And I'm talking here about uninformed treatment without full discussion of the individual HIV prevention benefits, as well as the risks of earlier treatment, and rather than for the broader public health. A couple of examples of, here's a major challenge, mandatory testing. The problem is that although the initial concerns about a policy of treatment as prevention leading to forced treatment might not be currently being seen, there are some very real and difficult issues in terms of mandatory testing. They are real and they are happening, and laws are being passed now, for example, in Uganda and in Botswana, and also in Greece, that allow for the mandatory testing of people who are seen to be a public health risk. And so this is not just an issue for the global south, but is happening in Europe too. These laws exist. But also, when we're talking about punitive laws and policies, it has actually had some positive benefits, particularly in Europe when we're talking about the impact of viral load on infectiousness. The Swiss statement from 2008 was actually created primarily to deal with an overly punitive criminal law in Switzerland. And I presented a poster on Tuesday that shows exactly where the impact of viral load on infectiousness on an individual level is having a positive impact on punitive laws and policies. Now, I'm here to talk about the community, and of course there are many, many communities. But I want to focus particularly on this community consensus statement on the use of antiretroviral therapy in preventing HIV transmission that was a joint project of the European AIDS Treatment Group, of which I'm a member, and NAM, who are the official scientific reporters for this conference, aidsmap.com. I wasn't involved in the creation of this, but I certainly influenced some of the later drafts. And this community consensus statement, I think, reflects very much where we are in terms of all the different communities of people living with HIV and affected by HIV. And I'm just going to read a few key points. The aim of the statement is to safeguard the health and well-being of all people with HIV and their freedom and the power to take or not to take HIV treatment. Antiretroviral therapy can potentially free people with HIV from a huge burden of guilt, blame, and anxiety about infecting others. Taking HIV treatment to reduce one's infectiousness is a benefit and not a responsibility. Taking antiretroviral therapy is a decision people need time to consider, and they should not be pressured into it. Providing antiretroviral therapy for prevention must not deprive people who need it for treatment. Antiretroviral therapy should not be adopted as the sole component of HIV prevention programs and should not replace existing effective methods. In many places, people who most need antiretroviral therapy have the worst access to it. This is largely due to stigma, persecution, and criminalization. And the prevention benefits of ART cannot be realized until these are addressed. Many people, with and without HIV, are unaware of ART's prevention potential. They need clear and accurate information about it. ART will not succeed either as treatment or prevention without free or affordable access to tolerable drugs and the support to take them. And ART by itself will not end the HIV epidemic, but it is an essential component of what it will take to end it. I'd just like to highlight some helpful frameworks and guidance that I have been working on with many brilliant colleagues. There's a policy framework as well as operational guidelines to help policymakers and HIV program managers to understand how best to approach treatment as prevention in a way that benefits public health and human rights. It's called Positive Health, Dignity and Prevention. It's produced by the Global Network of People Living with HIV along with UNAIDS, and it's available at the URL you can see on the slide. I'm also very happy to say that I worked with the IAS and Julio as well was part of this, to produce concise guidance for HIV healthcare providers on the use of art for prevention that was launched yesterday. And this provides individual guidance for healthcare workers, placing things within a human rights framework. And finally, I'd like to ask all of you who are HIV health professionals, and that actually covers a wide gamut of people working in the HIV response, to sign up to the IAS new Code of Conduct for HIV and health professionals, which again has a human rights framework. Thank you very much for your time.
Good morning, everyone, and I believe that at every point of our life, good or bad, we need a break, so this will be a break, no PowerPoint presentation, but yes, I'm going to take you somewhere to a place where I come from. I work with ACW Asia Pacific as the coordinator and based in Bangkok, Thailand. But I'm from India, from Nagaland, one of the remote states in India which borders along Myanmar. So before I share my perspective on treatment as prevention, I just want to tell you that be ready, because I'm going to take you to a place called Pangsha. They're also going to be bumpy, dusty, and after a few kilometers we're going to walk. I do believe, and I have seen that treatment do work in terms of transmission of virus, and I can say this because I know many of my friends who are HIV positive, but whose spouses and children are HIV negative, and it's all because of treatment. And it's not just friends, but I have come across people who says that treatment really works, who have stories to tell that it does works on prevention. But like I said, does it work universally? So let's go. There's a place I come from a district called Tueng Sang in Nagaland, and beyond Tueng Sang, it's the Indo-Myanmar border. There's a place called Pangsha. And surrounding Pangsha, it's a small village. There are again 2-3 clusters of small village where the total population is around 6,000. And it is not very far from the Indo-Myanmar border. Now, according to the latest report, since 2006, 104 people are tested HIV positive. And I remind you, not all 6,000 people, the total population is 6,000, not all 6,000 went for HIV testing. And the nearest health center that they can get access to for any kind of service is again many kilometers away from that very particular village, which is called Noklak, where we have a link ART center. It's just a center to provide the medicine. But for all the other diagnostics and other clinical examination, clients have to travel to the district headquarters, which is Tueng Sang. Now, just to pick up the ARV drugs, they have to either walk or take a motorcycle, two-wheeler, which serves as a taxi, two-wheel taxi, to go to Noklak. To coming to Tueng Sang town, it's like a dream. And the cost of this two-wheel taxi is around $10 to $12 US. And these clients, these people living with HIV in this area, are mostly daily wage earners whose daily income is $4 to $5. So it is not possible for them to spend $10 to $12 just to get medicine. And with the alarming rate of HIV infection, aggravated by lack of proper transport communication and lack of health service center in these places, treatment as prevention is not working universally. And I am sure that it's not just there in Pangsha or nearby area. This problem is faced everywhere across the border or across the region. It does work, right, but only in urban settings or in the settings where the treatment is easily available or it's accessible. So the biggest challenge is how do we take the whole package of this treatment and care to the rural areas so that HIV-related deaths and new infections are prevented. Another one of the greatest barriers in access to treatment across the universe, irrespective of rural or urban setting, is stigma and discrimination. And because of the presence of these factors, we are not able to achieve the target on treatment. Criminalization of certain key affected population drives them away from coming out in accessing treatment. And if we are not able to achieve the target on treatment, then treatment as prevention won't work again. We also need to understand that if a client who is healthy does not wish to start ARV, then it should not be forced. For example, in the case of positive pregnant women, the introduction of option P+ by WHO, which was introduced with all good intention, is also a factor why there is a lot of loss to follow-up cases owing to many reasons. I'm very sure that every woman who is pregnant wants to save, does not want the baby to have HIV. But why does a pregnant woman has to continue treatment if she's healthy enough, if her CD4 count is high, if her viral load is good, if she's at the very first clinical stage, if she is at the clinical stage 1, then why would she continue the treatment if she doesn't want to? So I kind of think, where is our right if we want to continue treatment or not? Where is our voice? Forcing someone to start treatment just for the sake of preventing HIV transmission is a violation of human rights. Because it is not easy for us to be mentally prepared. First of all, you go to the center, you get tested, and you're being told that you're HIV positive, and suddenly you're being told that, okay, you need to start treatment, which is lifelong. And also, it has an extra package, which we all know it's the serious side effects, whether it might start during the start of your treatment, but if not, it eventually will come. The side effects eventually occurs in the long run. So where is the quality of care that we all talk about, care, support, and treatment of people living with HIV? I don't see any care, and unless these issues are addressed, there will be lots and lots of loss to follow-up cases among positive pregnant women and among key affected populations, especially from the population of drug users, the MSM, transgenders, sex workers, etc. And to me, as a community, as a person living with HIV, I think that the best possible results with regards to treatment or as prevention can be achievable with 3 things which I want to share. It's the scaling up of services, but not mandatory, through various settings, including community-led testing. Providing treatment should be accessible to all, no matter where they live. Infrastructure should be established in every places where PLHIV can access treatment and related service. If governments and policymakers think that it is not possible to set up huge infrastructure in a remote village with no electricity, no proper means of transport, then at least provide with human resources. Human resources should be made available so that the services are reached to those in need and those who cannot make it to the centers. Providing transportation and cost and shelter, home or halfway home for those clients coming from hard-to-reach place to the district headquarters should be included. And counseling should not be only once or twice. That's when the clients come to the center. It should be continuous, and follow-up mechanism should be in place to strengthen so that clients adhere to treatment and ensure that there is no loss to follow-up cases. Addressing stigma and discrimination and the human rights barriers that impedes in the uptake of testing and treatment. In a country like ours, where HIV is concentrated among key affected population like drug users, sex workers, etc., treatment as prevention is not going to work if the legal issues related to these groups are not addressed. Besides providing ARV drugs, more emphasis on prevention program with comprehensive service package should be given according to the needs of the specific population. The countries need to ensure that all laws and policies that act as barriers for key affected population, even PLHIV, should be addressed in order to work, so that its treatment as prevention will work. Thank you.